Thanks so much for the invitation. Let's talk about this subject. First of all, how many of you can raise your hand, how many of you perform or do balloons, intragastric balloons? Well, probably in Mexico City, half of the surgeons, we do it. It depends where you do it, but most of us, we like it, but it's not for every patient. So these are my disclosures, but the main one is that after sleeve and gastric bypass, probably the third most common thing I do is gastric balloons. And it's been more than 10 years that we have been doing this, and we have the advantage of having several types of balloons in Mexico. So here in the US, it's just the number of balloons that you're performing, it's quite stable. It's less than 2%. This is different in some other parts in the world, especially in Brazil. A lot of experience of all these endoscopic papers we have seen, even also in balloons, comes from those groups. And as we saw in the first talk, here, at least in the US, we're not really doing nothing for a lot of patients. We are skipping a third of patients that might be candidates for something. So there's something else that we can do? Yes. So I call this, we can fill the gap. Sorry, there are some Spanish words there, but pretty much the same. So if we do this as an exercise from 0 to 6 or 5 or 6 in terms of morbidity and up in terms of efficacy of cost, we can start from diet, which is not the most powerful thing we can do, and then we can go up to even a BPD or a gastric bypass. So there's a gap here that we can do something, and it also goes with a BMI that also requires, or they're not maybe, you cannot operate on those patients. So there are a lot of patients that we have here, and we can do all these things that we have been talking about, and this is the place where we can put a balloon. Also, after balloon, we can have the endoscopic sleeve. Maybe we put a band there, but normally we don't do it anymore. We can have the gastric clip there, the bariatric clip, which is a good thing that probably some of you have heard. And what are the candidates? This is a good thing. Almost every patient can have a balloon. Yes. If you have BMI above 26, you can have a balloon, but we have to focus on contraindications. The Brazilians, they say that we can place a balloon starting from 12 years old. That might be quite radical, but what are we going to do with those patients? Surgery is not that easy. We already saw in this morning the pediatric session. We can do drug therapy. It might work, but maybe 12 years old. I don't do it, but it's there. Of course, gastric ulcers, big hernias, because it's very hard to take the balloon out, and you have a lot of reflux. And of course, gastric surgery, this might sound quite logical, but believe me, I have seen one patient that one doctor put it after a Nissen fundoplication. You can imagine the disaster. So I call this real life indication. This is what we see in our office. Normally it's people with BMI below 30, below 32. A lot of them, we saw it previously, they're afraid of surgery. So they say, you know, I want to do something, but I don't want them to cut my stomach or whatever. So I call it training, because I say to these patients, let's try this for 1 year, 6 months, whatever. You're going to be the one that's going to tell me I need surgery after this, especially those that are candidates for surgery, of course. The other thing is bridge therapy in terms of BMI, especially above 60, maybe not 50, but above 60, 70 of BMI. That's a good tool. We don't need the balloon 6 months, 12 months. After 3 months, you can take it out and do the surgery. And also other indications for high-risk surgeries. So we always trying to look how things work, you know. So the model of action, there are a lot of papers there. The gastric capacity, of course, you have lower gastric capacity. The gastric emptying is lower, and then you have a lot of things there. But let's be honest, this is the main reason why it works. It hurts, yes, and you have a lot of GERD, especially the first month. And also the diet we're using the first month, it's pretty much like a bariatric surgery. So that's one of the main reasons this therapy works. So we have a lot of pros, which is few contraindications. You don't need really an extensive workup, except maybe for those above 60, yes, but if you have a patient with overweight, you don't need too much before putting the balloon. It's less invasive, it's ambulatory. You have few complications, less than 1%. You don't need supplements, you don't need vitamins. You can put it in 20, 30 minutes. Sedation, yes, but if you have a high BMI, you might think about a real anesthesia. And this is another thing that's where everything is going right now, to add some drugs after the plateau to help more, to induce more weight loss. But there are a lot of cons also, symptoms. It's worse than a bariatric surgery, for sure. Especially the first 3 days, these patients have a very, very bad, a lot of nausea, a lot of vomiting. It changed a lot for us when we started to use the spats, since we don't need to take it to 700 cc's. With 400, it's well tolerable. You can tolerate it more, but even though you have a lot of symptoms. So the other thing is you need to use a lot of medication for nausea, and you need the good drugs, which are very expensive. You need to use PBI for 1 year at least. You have a lot of reflux pain, yes. Yeah, bad breath, and whatever comes with anything that is not surgery, which is poor results after 1 year. That's the main thing. So what options do we have? A lot of options. I know here you only have 2 or 3, but there are more. You have the liquid or air. You have balloons of 4 months, 6 months, 12 months. 1 balloon, 2 balloons, 3 balloons. You can adjust or not, and you can use endoscopy or not. So this is the main question. If you have 6 different balloons, which one are you going to use? It depends a lot of things, and most of the things depends of the patient. So if we have, here we have the 6 balloons that are most widely known. We have the Orbera, the Reshape Duo, Obalon, Heliosphere, Spats, and Ellipse, which is Allurion right now. So the Spats, it's recently approved by the FDA, and this is the one that we were using since 5, 6 years ago. We stopped doing the Orbera because it's only 6 months. And also the Ellipse, it's no longer called. That's Allurion system, which is new in Mexico. We have been doing it for 2 or 3 months. It is good. So if we can spot certain things about each balloon, we can say Orbera, it's like the father of the balloons. It was the bib, and it changed names, whatever, but it's the same. So it used to be a 6 months balloon, but now with the Orbera 365, we have the 12 months balloon, but we don't have too many papers with results, but I believe it's going to be a little bit like Spats. So the Reshape Duo, we know that's 2 balloons that we can inflate after one, and then 3 months later, you can inflate the other one. And the Spats, you have 12 months. It's the only one that you can adapt, which is good, because sometimes you have a patient that they spend money on their balloons, and 3 days after that, they say, I cannot tolerate this, so we just go inside, we deflate a little bit, not less than 400 cc's, because it can go to the bowel, but it helps a lot. And then we can do it again. And the other thing with the Allurion system, it's that it's expensive. It's more expensive than the others, but the patient that doesn't want an endoscopy, it's very good, because you just swallow the capsule, you have your x-ray, and you just go and put 500 cc's, which is, again, another problem. We stopped seeing a lot of intolerance. Now we're starting to see it again, because there's no way you can put less than 500 cc's with the Allurion. So, and this is another thing, the resources, your hospital, can you do endoscopy, can you do it or not? The cost, of course, is different in every country, but these are other things that you have to take in mind. So these are the options we have. The Obalon, we started using it like 7 or 8 years ago in Mexico, but a couple of patients had problems, so the Mexican FDA stopped the register for Obalon, because one patient had a hiccup when the balloon was filling with air, and it made a hole in the esophagus, so it was a very bad problem. So if we want to know the results, these are the main papers that we have seen, and they're pretty much the same. We have around between 11 to 15% of total weight loss. It depends when you're measuring it, but they work a little bit like the endosleep during the first 6 to 12 months. After that, of course, we have to remove it. So this is the big question. Does size matters? Yes and no. Yes, in terms of symptoms. We don't need to put 700 cc's, that we already know. But does it have an impact on weight? No. It's pretty much the same, so we can manipulate the amount of liquid we're using in the SPATS balloon, of course. Again, this is the real-life results. I know in meta-analysis and randomized control trials you have very nice numbers, but this is pretty much what we see. Of every, like 100 patients, less than half after 6 months of the removal will prevail with a sustainable weight loss, and this is less than 20% of excess weight loss. So this is the real deal. There are few patients that will come back and say, you know, please, I want a balloon again. And those patients, we try to make them go to surgery if they're candidates. And almost to finish, we published this 10 years ago, where we started to see how to lower the risk in extremely high BMI patients, and it really worked. Of course, if you're an experienced surgeon, this might not be such an impact, but if you don't have that much experience, you need to lower the BMI as low as you can. I always tell my residents not to go further than 55 BMI in their first cases, so this might be a good therapy for them. Another thing that everybody asks is, okay, I do the balloon, I take it out 3 months after that, when can I go for surgery? It depends. If you go for a sleeve gastrectomy, you have to wait at least a month and a half, at least, because you have a very thick wall. If you go to a gastric bypass, you can do it after 3 weeks because it's different where you're gonna do the final stapling. So that's a thing that you have to consider and try to use wide loads, green loads, okay? So this is working, but the future is different. All these things are right now the hip, where they're trying to do balloon therapy all along with the endo, I don't remember the name of the endo sleeve or whatever. All these things are done, you know, in the Mayo Clinic with Abudayev and Manuel Galbao, our dear friends. This is another thing that's going to start this March, actually. It's a combination of a balloon with an endo sleeve. It's not two devices separated. It's the same device. And what I think this is more promising is the use of drugs. When the patients reach this plateau, some of them, they want the balloon to be inflated more. And I say, you know, we can try drugs. There are a lot of things that work. We already saw this morning also. So all the new trials are aiming to do like a booster therapy. It's pretty much the same what we're doing with sleeves or gastric bypass, whatever. Patients with weight regain, these drugs are a very good thing. So in conclusion, the intragastric balloon is an effective therapy, but also, as any other bariatric surgery, patient selection is the key. You have to take care of cost. It depends on the country where you're using this. In Mexico, SPATS will be all along, like 3,000 US, so it's not that much compared with the surgery. We have more indications. It's not only for the girl that wants to go to the wedding of a friend and want to lose some weight. No, we have more indications for that. And I think that we have to do it as a combined therapy. Thank you.